Hello everyone, welcome to HIM 225. This is a continuation of the lecture for Chapter 21. And if you would please turn to page 514 in your textbook, and we're going to talk about benign prostatic hypertrophy. In the index, if you put in hypertrophy prostate, it tells you to see enlargement, enlarged prostate, and so we are going to do that. Now, this sends us to category N40, which we're going to go to that. Now, when you look at these codes, we have a code N40.0, which is BPH, which is how it's commonly always referred to, without lower urinary tract symptoms, and that is LUTS. So you can have BPH with LUTS and BPH without LUTS. So this is BPH without LUTS, and then BPH with LUTS is N40.1. Now, I want you to notice that you have an instructional note here to use additional code for associated symptoms when specified. So very commonly, the way that men know that they have an enlarged prostate is they begin having symptoms. And they may have some of the common symptoms is that they may have hesitancy. So they have a hard time getting their stream started. They may have urgency. They may have urinary retention. They can't fully empty their bladder. Sometimes this can cause urinary tract infections. And you'll notice that these codes start with an R. What do we know about R codes? Those are sign and symptom codes. And what do the guidelines tell us? If we have a definitive diagnosis, we don't use a sign and symptom code. But this is the exception that is specified in the classification system. If you have a patient that has benign prostatic hypertrophy and any of these symptoms are documented, you code them, even though they are from the sign and symptom chapter. So that's very important to note with BPH. Also, nodular prostate, again, these prostate codes that deal with enlargements and nodules on the prostate, the classification system instructs you to code those signs and symptoms. I want you to look on page 515 in this first example, chronic prostatitis due to staphylococcus. So we're coding the chronic prostatitis, and then we're coding the staphylococcus as the organism causing a disease classified elsewhere, B95.8. PSA is a protein that's produced by the prostate gland. There's a blood test that measures PSAs in males, and it is actually a screening for a prostate cancer. So if the PSA level is elevated, then there is a risk that that patient may have prostate cancer, or they might have BPH or prostatitis. So in this example, the patient was seen in the clinic for an elevated PSA, and they determined that the patient had severe prostatic hypertrophy, and that was the cause. Now, there are no LUTs here, so that code is N40.0. In the next example, a patient was referred to a urologist for elevated PSA. So this is a sign and symptom code. And in the index, you can go to elevated, and then you'll find PSA, R97.20. And we can look at that in the index, and elevated PSA. And you'll notice that it's in a category for abnormal tumor marker. Tumor not necessarily meaning cancer, just meaning some type of neoplasm. Now, it's important to notice that the disorders of the breast that are in this chapter are not related to pregnancy. Those are in the pregnancy chapter. And of course, if it's a malignant neoplasm, then it is coming from a neoplasm, it's coming from the neoplasm chapter. For this lecture, exercise 21.6 on page 517, I want you to answer question number 1. When we talk about procedures that are relative to this chapter, one of the most common ones is hemodialysis for renal failure, and that is discussed on page 523 in your textbook. One of the things that is done to accomplish dialysis is the creation of an AV graft for dialysis. And this is typically done as an inpatient, not always, but usually it's done as an inpatient. They'll put in this AV graft, and then they will actually perform dialysis in that setting to make sure that it's working appropriately. The formation of one of these AV fistula, the grafts, the shunt, is a bypass, because they are actually altering the route of passage so that the blood can get from the body into the machine to clean it. So in the index, we go to bypass, and they're bypassing the radial artery. And of course, whatever documentation that you are reading will clearly document what is going on. So you just need to know that the root operation is bypass. The artery is the radial artery, and the example in your book is the left radial artery. So we're at the table 031C, and it is an open approach. They use a synthetic substitute. They actually have a port that they put in, so it's open. We have a synthetic substitute, and then we are bypassing to a lower arm vein. So that is the coding for this AV shunt. You'll recall that when we went through PCS, we did look at transplantation codes. And so in this instance, we're doing transplant of a kidney. And I just lost it. Darn it. So we're looking at a kidney transplant. The table we used depends on whether it's left or right. We'll choose left. It gives us the full code. Well, it doesn't. We have to choose the qualifier. So we have to know where this kidney came from. And typically it is from another patient. And so our qualifier is allogenic. For procedures on the prostate, the most common procedure is a transurethral resection of the prostate. It's referred to and called a TURP. The intention is to completely resect the prostate. So the code that you typically are using is 0VT0. Unless they tell you that they are only removing part of the prostate, you're going to assume that it is an excision. Your book talks about a number of other procedures that are performed on the prostate, and you can use these acronyms to find those procedures in the index, which makes it very easy, very handy to do. We're going to look at a TURP, or we're going to look at this example in the book, and this transurethral resection of the prostate, it's performed via a cystoscopy going through the urethra, but the cystoscopy is the approach, so it is not coded. In this particular example in your book, they're doing a radical prostatectomy. So this one is not a TURP, the example in your book. And so we would be coding a resection of the prostate. And that table is 0VT0 for the prostate. We know that this procedure is open and there's no device and there's no qualifier. In addition to removing the prostate, they also removed the bilateral seminal vesicles, and they removed lymph nodes in that pelvic region. In this same table, we can see seminal vesicles bilateral, and it's open with no device and no qualifier. But then for the lymph nodes, this is not a resection. It is an excision of lymphatic, and it's in the pelvis. So we're at table 07BC. This also was open and there's no device, and this is diagnostic. They're taking out those lymph nodes because they want to see if the cancer is in those lymph nodes. So that is how we would code this particular example. On pages 528 and 529, they do discuss procedures on the breast biopsies, which of course is an excision and it's diagnostic since it is a biopsy. They also discuss the resection of the breast with the construction of the flap, the tram flat. And in the index, if you put in tram, you will see for under its replacement, and you can go to table 0HR, and let's go to that table. And then you choose the appropriate body part. And in this example, this particular example, it is the right breast. And so we are going to choose breast right. It is an open procedure, and we are using an autologous tissue substitute. It's from the patient, and this is a TRAM, transverse rectus abdominis myocutaneous flap, and so that is how we find that code. Patients with kidney stones often have lithotripsy. It is extracorporeal shock wave lithotripsy, ESWL. It is fragmentation. The approach for this is typically external because they put the patients in a tank. Sometimes it is not, but many times it is. And you can see by looking in this category of fragmentation that we do have, there's bladder neck, common bile duct, and then there is kidney pelvis, and then we do have ureters. And so obviously you're going to be looking at the documentation that provides you with the exact location. Many times this approach is external and there's no device and no qualifier. And of course you'll use the documentation that you're coding from to determine that. For your homework, you have a workbook assignment and the chapter review questions. And your chapter review questions are, you're answering odd 1 through 9, and then you're skipping down and answering 13, 15, 17, 21, and 25. So let's go over those. For number 1, you have one answer. For number 3, you have one diagnosis code. For number 3, you have 3 diagnosis codes and 1 procedure code. This patient has benign prostatic hypertrophy. They have urinary obstruction. They have a history of a renal calculi. That is a Z code. And they're being admitted for a TURP. After the procedure, the patient had slight hematuria. However, that hematuria is to be expected. That is not something that you would code. Number 5 has 1 code. Number 7 has 2 codes, menometrorrhagia and chronic blood loss anemia. Number 9 has 2 codes, a diagnosis code and a procedure code. This patient has hematuria, and they had a diagnostic cystoscopy to inspect the bladder. Now for number 13, this patient has chronic glomerular nephritis due to amyloidosis. This is 2 codes. Number 15, infertility due to azoospermia. So you're going to have 1 code for this. For number 17, this is a little more involved. For number 17, we have 3 diagnosis codes and 4 procedure codes. This is an open total abdominal hysterectomy. When they do a total abdominal hysterectomy, they remove the uterus, they remove the cervix, and they move the right. They do a salping oophorectomy on the right and the left. And why? And that's your 4 codes: the hysterectomy, the removal of the cervix, and then oophorectomy on the right and left. And why did they do this? Because this patient had uterine fibroids and a follicular cyst of the right ovary. Those are your 2 diagnosis codes, and a family history of cervical cancer. That is the Z code. Then for number 21, we have 2 codes, a diagnosis code and a procedure code. This patient has postmenopausal bleeding, and they perform a therapeutic dilatation and curettage of the uterus. This is a non-obstetric D&C. Okay? For number 25, there is 1 diagnosis code and 2 procedure codes. The patient had a bilateral laparoscopic oophorectomy with bilateral salpingectomy due to polycystic ovarian syndrome. So we have our diagnosis of polycystic ovarian syndrome, and then the procedure was laparoscopic, and they did a bilateral oophorectomy and a bilateral salpingectomy. So obviously, since you don't have 4 procedure codes, you know that you're looking for bilateral codes. Then for your workbook assignment, you're completing the glossary definitions, odd 1 through 19, and then you're coding case scenarios. So in your workbook, let's go to chapter 21 and look at those case scenarios. We're doing 1, 5, and 9. So we are on page 249. So for number 1, this is a 60-year-old female who came in for repair of a large cystocele and a small rectocele. They had surgery. They had a cystocele and rectocele repair. This was via an open approach. So you're going to have 2 diagnosis codes, 1 for the cystocele, 1 for the rectocele, and you're going to have 2 procedure codes for the repair of the cystocele and the rectocele. Now, when they are performing a cystocele and a rectocele repair. They are repairing the subcutaneous tissue of the pelvic region. And I'm going to tell you that the code for the cystocele repair is the same as the code for the rectocele repair. These are two distinct procedures, but they actually have the same code, and in this instance we list them twice because one is cystocele and one is rectocele. So remember, that's repair subcutaneous tissue in the pelvic region. Okay, let's look at number 5. And that is on page 250. So this patient was admitted for investigation of microscopic hematuria. So the patient is going to donate a kidney to a family member, and any renal disease must be ruled out. So the patient had a percutaneous needle biopsy of the left kidney. That's our procedure. The patient has a past medical history of GERD. That's being treated for Nexium. So if they're currently being treated for something, is it a past history or do we code it as a current condition? The patient also had a pneumothorax caused by an MVA years ago. So if they had a pneumothorax years ago and it's not affecting their care, do we even code it at all? So this final diagnosis is kidney donor with microscopic hematuria, and the procedure is a diagnostic kidney biopsy. Now, I'm going to tell you that the condition that they are investigating is the microscopic hematuria. We know that the patient has gastroesophageal reflux disease, which is the GERD. This patient wants to be a kidney donor, but they're not yet because they have to determine first what's causing this microscopic hematuria. So you have two diagnosis codes, and then you have the procedure code for the biopsy of the kidney. So what root operation is biopsy? And it's the left kidney. And it's a percutaneous needle biopsy. And it is diagnostic. Okay? Now, let's look at number 9. In number 9, this patient was admitted for treatment of BPH, benign prostatic hypertrophy. This patient has urinary retention. They have a history of frequent urinary tract infections. You can code that. The PSA was normal. So they performed a TURP. The patient recovered uneventfully with minimal hematuria, which was resolved. That means we don't code it. So our final diagnosis is benign prostatic hypertrophy and then transurethral resection of the prostate. So when we're coding this, there are 3 diagnosis codes and 1 procedure code. You're coding the fact that they have benign prostatic hypertrophy, they have urinary retention, and they have a history of frequent urinary tract infections. Now that is going to conclude this lecture for Chapter 21. If you have any questions, please contact your instructor.